So welcome everyone. My name is Jackie Gear and I'll be moderating today's sleep seminar. And I have a few quick announcements before I introduce our speaker. So first of all, as usual, to receive CME credit for attendance, please see the chat room for instructions. Those will be updated a few times throughout the talk. If you have any questions during the presentation, it'd be great if you could put those in the chat room during the meat of the talk, and we can address them at the end. Or if you would like to ask the question out loud, you can unmute yourself at the end of the talk as well. And finally, please feel free to share the announcements for these weekly lectures to anyone who may be interested, and Debbie Lovejoy can add anyone to our email list. So with that, it's my pleasure to introduce our speaker for the afternoon. This is Dr. Julie Baughn, who's an assistant professor of pediatrics and associate director of pediatric sleep medicine at the Mayo Clinic College of Medicine in Rochester, Minnesota. Dr. Baughn received her medical degree from the University of Wisconsin School of Medicine, and she completed residency in pediatrics, where she also served as a chief medical resident at the Medical College of Wisconsin. She also completed fellowships in pediatric pulmonary medicine and sleep medicine there. So Dr. Baughn has had a deep commitment to education in pediatric medicine, particularly in sleep medicine. She's served in several leadership roles in the Pediatric Pulmonary Fellowship Program, as well as the Internal Medicine Program, and is the current Associate Director for Pediatric Sleep Medicine Trainees. She frequently speaks at national meetings and conferences and leads several courses for trainees. She's very committed to quality improvement in sleep medicine and ran a project aimed at enhancing the patient and family experience during pediatric sleep studies, which are challenging. And this will be the focus of her talk today. So without further delay, please join me in welcoming Dr. Baughn for her talk entitled Enhancing the Patient and Family Experience During Pediatric Polysomnography.
Thank you so much for that kind introduction, Dr. Gear. I'm thrilled and excited to be here. I really appreciate the invitation to come and talk about some of my research in this area. This is the CME code. I did place this at the end, and I believe it will be in the chat as well. I do not have any conflicts of interest to discuss, and I will not be talking about any off-label use of medication today. So here are some of the learning objectives where we'll talk about some of the challenges parents and caregivers face during pediatric sleep study. We'll discuss how we applied various business models to enhance clinical practice.
I'm so sorry to interrupt. I don't see the slides. Does anyone else not see the slides? It could be a me issue, but
I don't know.
I see the slides.
Okay. I see them now too.
You too. Okay. All right. So we'll discuss how this impacted patient and caregiver satisfaction, and we'll discuss how adequate preparation for children and their caregivers prior to sleep studies is key. So just so we're all on the same page, I know not everyone in this talk practices pediatric sleep medicine or routinely cares for children, but the gold standard for diagnosis of pediatric polysomnography is, or gold standard for diagnosis of pediatric obstructive sleep apnea is polysomnography. Home sleep apnea testing is available in some instances, but is not kind of our first line therapy for children. And we'll talk a little bit about that. And then overnight oximetry is in general not helpful as a screening tool for obstructive sleep apnea. So contrasting that with adult sleep medicine. So our clinical history as well in pediatric sleep medicine is really a poor predictor of who goes on to have sleep apnea. Children don't snore as loud as adults. They may or may not have a bed partner. They are more prone to partial airway obstruction and less prone to overt apneas. They can contort their bodies in different positions, extend their neck, sleep in the prone position, and keep that airway open. And as obstructive sleep apnea occurs predominantly in REM sleep, which is clustered at the later part of the night, it may not be observed by parents. So if a child is sleeping, generally the parent is sleeping, and so they may not observe that. We need to assess for snoring and have follow-up questions if indicated. And the American Academy of Pediatrics and the American Academy of Sleep Medicine recommend a sleep study when available prior to adenotonsillectomy for most children. So again, we need that gold standard of polysomnography for more children now before they get their tonsils and adenoids removed. The American Academy of Otolaryngology also recommends a sleep study prior to getting the tonsils and adenoids out if there's a complicated past medical history, if there's a history of obesity, a history of Down syndrome, craniofacial abnormalities, and then advocates for a sleep study where the tonsil size does not match the history. So big tonsils in a child, not much history for sleep apnea, a lot of history of sleep apnea, but small tonsils, and polysomnography is recommended at that time. So many children getting tonsils removed is a very common procedure in the United States, and many children require polysomnography prior to that. And adenotonsillectomy is first-line treatment for most children who have sleep apnea. So what about sleep studies or home sleep apnea testing? At this time, the American Academy of Sleep Medicine does not endorse use in children at this time. I believe some of these guidelines are being updated, but the most recent published guideline from 2017 says, again, routinely, there's not enough evidence to recommend this in children. And overnight oximetry is similarly not a helpful screening tool. A study done in 2000 looked at children who were referred for symptoms of sleep disordered breathing and found that those with a positive oximetry were likely to have sleep apnea on polysomnography, but those with a more inconclusive or negative oximetry still went on to have sleep apnea about half the time. And kids have normal lungs. They're again more likely to have partial airway obstruction. And so we can see kids with significant sleep apnea that have a normal oximetry. So again, that brings us back to our gold standard of polysomnography. And also in children, we're often really dealing with this gray area. We have kids who have sleep concerns. Sleep concerns are extremely common in children. At least 50% of children will have some sort of sleep problem throughout their lifetime. And we're relying on parental parent perception of those sleep issues, and we're trying to sort out restlessness, obstructive sleep apnea, behavioral hygiene issues. And so especially in our medically complex children or younger children, there can be a role for sleep studies to really sort out all these issues. Again, most of these children are undergoing sleep studies for obstructive sleep apnea, but there's often these other factors at play. When we're treating children, we're really treating the whole family, and kids with sleep issues impact the whole family significantly. And it's important to remember that kids with sleep issues often have behavioral side effects. Adults who have sleep apnea, adults who have poor sleep are often sleepy, but kids are often hyper and have attention issues and behavior issues. And if you think of kids in your life who may be up past their bedtime, it's vacation, it's a holiday like this recent Thanksgiving break. If they're up past their bedtime and get overly tired, they do not go to bed easier. They get more and more wound up as the night goes on. And that's how children with sleep disorders are all the time for families. So families are already very stressed by this at baseline. So just a little bit of background on our sleep lab. We have an integrated pediatric and adult sleep lab. Our pediatric numbers have been growing, and I'll show some slides on that. And our practice sees all patients in consultation. So we really practice in this awesome system where every patient that undergoes a sleep study, I get to see in clinic before the sleep study, and I see them usually the next day after. And that follow-up the next day was, for better or worse, was really helpful in identifying some issues we were having with the patient experience for polysomnography, because we were getting that real-time feedback the next morning that things weren't going so well for parents and kids the night before. So I'd like to start with a case. This was a case that presented kind of around the beginnings of this project, and I really often think of this child when I'm thinking about this project and how this helped us launch into an improvement project for our sleep center. So this was a 3-year-old with trisomy 21 who presented for sleep study results. This was his 5th sleep study. He had a history of oxygen use as an infant, and it had adenotonsillectomy and supraglotoplasty, so multiple kind of pre and post sleep studies to determine if the treatment was effective. And at this time, he had severe obstructive sleep apnea. His age, I was 28. And that sleep study did not go well. Mom was extremely upset the next morning, felt like it was extremely traumatizing for her child. You know, she was a sleep study veteran. This wasn't her first time in the sleep center, but it just did not go well. And whether that was you know, again, that this child had all of this medical history, or just the age being 3, or maybe a little bit of, you know, again, what we could do to improve on this experience for her. But I needed to talk at least about CPAP with this mom. And that was a hard conversation when she'd had such a poor experience. And she certainly wasn't interested in doing a titration study right away to determine his pressure needs. So the patient experience significantly impacted my ability to make certain clinical decisions for this child. And this is just a picture we have of some of our sleep technologists setting up in adults, but you can imagine that polysomnography setup in children does not look like this at all. Does not look like a calm adult laying down comfortably holding still while the sleep technologists put all of those stickers with wires on them. This is just a slide to show that growth in our pediatric practice and how that was impacting things. So in 2017, we were doing 696 pediatric sleep studies a year, and that was only about 16% of the total sleep studies done between adults and children. So many of our sleep technologists, you know, they didn't necessarily sign up to be pediatric sleep technologists. They were doing them, but then, you know, our lab showed significant growth. And peaking a little bit in 2019, right before the pandemic, which showed some slowdown in growth. We also had a retirement at that time, and now we've had more significant growth since then. And in 2023, now pediatric sleep studies are making up about 40% of the lab, and that's been you know, simultaneous increase in pediatric sleep studies, with some decline in adult sleep studies. So getting those sleep technologists on board, that they need to be comfortable and we need to give a good experience to our pediatric patients, was really important. So polysomnography is, as we all are aware, is time intensive, it's expensive. For pediatric patients, it may require some time off for the parent caregiver. The parent and caregiver has to come stay overnight. They may be tired the next morning. They may need to take off of work, and it may be required prior to further intervention. So again, it's required often. We need those results before ENT can make their intervention and do a surgical intervention. So the importance of getting this test and how it may affect future treatment is extremely important. So on a good day, I think pediatric polysomnography is stressful and inconvenient for parents. We have a fairly medically complex population. About 40% of our patients are medically complex. And again, children with sleep disorders have attention, behavior issues, and hyperactivity. So again, getting them to sit still and lie still like that adult, getting hooked up for the sleep study is not going to happen. It's really developmentally appropriate for a toddler to struggle with a sleep study setup. It's developmentally appropriate for toddlers not to want people in their business. And that is just something that needs to be considered. And then many children, especially those with our special populations, those with special needs, may need multiple studies over time. And that's really, so it's really important that we get this right as to the best of our ability. On a typical day, in our clinic, a child may have a whole week of appointments in aerodigestive clinic, and they may have undergone in that same week a procedure under anesthesia with an FFB, BAL, EGD, MLB. They may have had a pH probe placed. So they may have had a medically traumatic week prior to their sleep study. They may have a diagnosis of autism spectrum disorder and have a sensory processing disorder, making those you know, that setup particularly challenging. And the child her initial sleep study may have gone well, but now they've had an adenotonsillectomy. They have to come back for another sleep study because they had moderate or severe sleep study. And that second sleep study can really be a challenge because, again, they've been through all of these other things medically. So when we were launching our project, we looked to the literature, and really there is not a lot in the literature looking at this or addressing this. There's a very nice paper from 2005 that really outlined a patient-centered child life model of pediatric polysomnography and a family-centered care approach. There was this paper in 2011 that was also prompted by a parent who said their child developed PTSD after a sleep study. So they looked at, was there any long-term sequelae from a sleep study, and they found in general that those were satisfied with the experience. They had already adopted a child-friendly approach, and they felt like that was really key to this being tolerated well. And there was a study as well that used some desensitization, but this was for home sleep apnea testing and in patients with autism spectrum disorder. So we did some benchmarking. We called some of our colleagues throughout the country just to get a sense what other people were doing, and use that in addition to this literature as a starting point. So we had this informal assessment that maybe we weren't doing things as we should. We had those verbal complaints the next morning, right around the time that the case I presented with the child with Down syndrome, we were alerted to a mom, and I'm not sure it was that mom of that patient, but I always link it together, complaining on social media in a Facebook group for moms of children with Down syndrome that she had had a bad experience in our center with a sleep study. Our institution uses Press Ganey. I don't know if that's something you guys are familiar with, but that asks a lot of questions about the clinic visit. It asks about parking, but really didn't ask questions about the sleep study experience. So we didn't really have a sense as to how that was going. And, with our project, we weren't able to add additional staff at this time. So even if we identified additional staff, that wasn't part of this improvement project. We saw lots of opportunities at that time. It's hard for me to believe this, but we had set up times and bedtimes that were the same as adults for children. Our floor looked drastically different than the other areas of Mayo Clinic that were dedicated to children. We have a floor in the Mayo building that sees a lot of the pediatric subspecialists, and it has this nice pretty tile with the drawings. And our floor is kind of dark green, maroon, looks like an adult floor. So we weren't really appealing to children that way. We found that communication and expectation setting throughout the journey from consultation to sleep study was inadequate. We felt like we needed to update some educational materials. And again, this was all while we were growing as a practice. So our project goal was to design a patient and family-centered approach to pediatric sleep study by implementing interventions from psychological preparation to strategies that can improve the quality and experience of the sleep study in order to meet the needs of the patients, their families and caregivers, and our staff. And while we were doing this, we had to really consider both the voice of the customer, which is the child and the caregiver, and the voice of the business, which first and foremost was Mayo Clinic, but also included the sleep technologists and pediatric providers. And balancing all of that was a challenge. We had a really awesome multidisciplinary team that made up our project. Sleep medicine leadership was involved, the pediatric sleep providers. Sleep medicine, the Center for Sleep Medicine is under adult pulmonary and critical care at Mayo, which is in the Department of Medicine. But the pediatric providers had joint appointments in pediatrics, and the Mayo Children's Center kind of oversees all pediatric subspecialists. And so Children's Center leadership was also supportive. We have an awesome department at Mayo called Management Engineering and Consulting, and they were able to help provide some of the framework for this study. We have an Office of Patient Experience that was involved. And again, we had leaders from all major areas of sleep medicine operations that were involved. And this was just a little diagram kind of outlining everyone involved. And I really think the involvement of the sleep technologists was one of the biggest key pieces. They were really frontline for the patient experience. We needed their buy-in and involvement. And, they work overnight. So again, making sure that we were connecting with them and getting that feedback was really key. But other members, our clinical desk staff, appointment office, nursing, it was all really important. This was published in the Journal of Clinical Sleep Medicine, and our Mayo Clinic Quality Academy gave it gold certification. We did a baseline satisfaction survey again because we did not feel that Press Ganey really captured the pediatric polysomnography. And so we created a survey that patients fill out leading up into the project initiation. And one of the members of the team created this customer journey storyboard, which I thought was awesome. It was a great way to kind of make sure we were all on the same page and make sure the sleep medicine providers kind of knew all the touch points this patient was having, that the desk knew what the appointment office was doing and knew what the sleep technologists were doing. And she made this journey storyboard of a patient kind of going through the process of referral for sleep medicine, check-in, sleep consults, getting scheduled for a sleep study, having the sleep study set up, and then the follow-up consult or results visit. We also did brainstorming, 1, 2, 4 all brainstorming, where we brainstorm individually and then you come together in larger and larger groups to generate ideas for improvement. And this brainstorming session again involved key members of that whole team. We also met with the Patient and Family Advisory Committee for the Children's Center. So this is a group of parents whose children have had medical complexity in general, and they provide advice to the hospital and the Children's Center. And several of these parents had completed a sleep study, and they really gave us a lot of great ideas of how to improve this process. And then there were also children with other medical complexities. And again, this really gave us a good voice of the customer. We identified some of our key drivers, which included expectation setting with the family, patient and family education, some flexibility of the rules, improving the environment and basic amenities, streamlining the check-in process, streamlining the patient's setup process and the checkout process, and then some possible interventions that we identified and that I'll talk about as we go through the next slides. We also use the Kano model, again, another business model where we talk about what are the must-haves for the customer, what are the satisfiers, and then what are the wow factors. And if you think about, something that may be a wow factor, like, keyless entry on a car, how that's now just a must-have for most new cars. And it was a wow factor years ago. So things that are wow factors become must-haves over time. When we were thinking about our project, we thought our must-haves were flexibility with the one-parent rule. So we had a rule where, again, we wanted just one parent to stay. There's not a lot of room. We don't want distractions. From a purely let's get the best test we can standpoint, having one parent there is probably better. But in our medically complex kids, that was really stressful for parents. So we determined that we could have some flexibility with that rule based on provider approval. We needed to have adequate expectation setting. We needed the families and the patients to know what they were getting into with an overnight sleep study. We needed to have an earlier setup time and an earlier bedtime for younger children. And then we needed to make sure we had some basic amenities and maybe a better setup process. That air gun that we were using for the EEG was really identified as something that was disruptive. Our satisfiers, things that we thought we would really want to implement, would be a child life therapist. We wanted to transition to EEG caps. We had been not using them up until that point. We wanted a child and family friendly environment. We wanted to implement a tour of the room and a video to prepare the patients prior to the sleep study. And then we discussed what would be some wow factors, like a goodie bag, a distraction box, a mattress topper to make that pull-out